Assalamu alaikum. I'm Dr. Hamd and welcome to my channel Anatomy Mentor. Today we're going to be talking about the gross anatomy of the orbit. So our learning objectives for today's session are that you should be able to describe the skeletal framework of the bony orbit and its communications. Also list and briefly explain the contents of the orbit. We will have a special focus on the extraocular muscles, in which we'll be talking about their attachments, nerve supply, and actions, and we shall justify their actions on the basis of their attachments. Also, we are going to apply the knowledge of anatomy to check the individual actions of extraocular muscles. So, what is the bony orbit? We know it is the pyramidal cavity which contains the eyeball along with some other structures. So, the orbits are bilateral bony cavities present in the upper half of the facial skeleton. And each bony orbit is in the shape of a hollow quadrangular pyramid. Now, when we say quadrangular, we know that it has four sides. With the wide base, which is opening anterolaterally onto the face, but the apex of the pyramid, it extends posteriorly and medially. So here is the orbit. You can see that this is a quadrangular pyramid. It has these four walls: the roof, the floor, the medial wall, and the lateral wall. Whereas this is the base of the pyramid, which is opening onto the face anterolaterally. This here is the apex of the pyramid, which extends in a posteromedial direction. So these are the two bony orbits. And if we look at these bony orbits from above, if we take a section over here and we look at these two bony orbits from above, we can see that their medial walls are parallel to each other. And here are the lateral walls of these bony orbits. Between the medial and lateral walls, there is the angle of 45 degrees. And if we were to extend the lateral walls of both the orbits posteriorly, they would meet, forming this right angle of 90 degrees. So there are two axes that you need to understand whenever we are considering the orbit. One is the axis of the eyeball, which is also called the optical axis, or you could say the line of symmetry. And the other one is the axis of the orbit. Now here you can see the dotted line, which is representing, if you follow the laser pointer, this is representing the optical axis when both the eyeballs, they are faced anteriorly. Then through the center of the pupil passes this line of symmetry or axis of the eyeball. Whereas if you follow my pointer now, you can see that the dotted line over here is representing the axis of the orbit. This axis of the orbit, and you can see here the axis of the eyeball, are meeting at an angle, right? If we were to follow this axis of the orbit posteriorly on both sides, they would unite and form an angle of 45 degrees. Here you can see this is the quadrangular or the pyramid shaped. You can see the bony orbit from above. The blue lines represent the medial walls of this orbit. Like I told you before, they're parallel to each other. Whereas the red lines, they represent the lateral walls of the orbit, which I showed you before. If traced posteriorly, they would form a right angle. And if we look over here, this is the axis of the orbit, which is the green dotted line. The axis of both orbits, if traced posteriorly, they would have an angle of 45 degrees with respect to each other. And the line in yellow is simply representing the axis of the eyeball, also known as the optical axis. Okay, so now that we've understood the axis, let's come to the skeletal framework of the orbit. 7 bones, they form the framework of each orbit. These 7 bones are the maxilla, zygomatic, frontal, ethmoid, lacrimal, sphenoid, and palatine bone. So these are the 7 bones which are going to form the bony orbit. Now here is a color-coded model of the orbit, and over here we can see this is the left bony orbit, and they are the different bones which are forming the bony orbit. When we talk about the orbital margin, we simply mean this orbital rim, and this orbital margin is formed by the bones which are the frontal bone above and laterally the frontal as well as the zygomatic bones. And inferior orbital margin is formed by the zygomatic and the maxilla bones, whereas the medial margin is formed by the processes of the maxilla and frontal bones. So these are the bones which are forming the margin of the orbit. Now, what about the walls of the bony orbit? I told you before that the bony orbit is a quadrangular space. So this means it has 4 walls. The superior one is known as the roof of the orbit. The inferior wall is called the floor of the orbit. And then there is the medial wall and the lateral wall. Now, if we talk about the individual walls, which bones are forming these walls? Well, the roof of the bony orbit is formed by this here orbital plate of the frontal bone. The orbital plate of the frontal bone is going to separate this orbit from the anterior cranial fossa, which contains the frontal lobe of the cerebral hemisphere. Now let's look at the lateral wall of the bony orbit, which is formed in front by the zygomatic bone and behind by the greater wing of the sphenoid bone. Now the floor of the bony orbit, it is formed by this orbital plate of the maxilla bone, which separates the bony orbit from the maxillary sinus. On the medial aspect of the, you could see the medial wall, this is formed by 4 bones from before backwards, or we could say in the antero-posterior direction. These 4 bones are the frontal process of maxilla, lacrimal bone, then the ethmoidal plate, which separates the bony orbit from ethmoidal sinuses, and then you have the body of the sphenoid. So these are the bones which are forming the medial wall of the orbit. Now, as we see, the orbital cavity has many openings or fissures. Let's summarize these openings one by one and talk about the important structures which pass through these openings. Well, the first one is the orbital opening. Over here, this diagram is showing us the right side bony orbit. And over here, we can see this is the orbital opening, which is simply the main opening, which you can see contains the eyeball, but not the whole of it, of course. It is the 1/6 of the eyeball, which is exposed anteriorly. The rest of the eyeball is protected by the walls of the bony orbit. So this opening anteriorly, the largest one, is known as, which is formed by the base of the quadrangular pyramid. It is formed by this opening called orbital opening. Now let's look at the other ones. Here is the supraorbital notch, which then forms the supraorbital foramen. It transmits the supraorbital nerve and vessels. Then we can see in the floor of this bony orbit is the infraorbital groove and canal, which contains the infraorbital nerve, which is the continuation of the maxillary nerve. And this over here, eventually, this infraorbital nerve exits from the infraorbital foramen on the anterior aspect of the face. Then on the medial wall anteriorly is located the nasolacrimal canal. So this contains the nasolacrimal duct, which is going to open into the inferior meatus of the nasal cavity. Now, in the posterior aspect of the bony orbit, we see the inferior orbital fissure, which is present between the greater wing of sphenoid and the maxilla bones. This inferior orbital fissure transmits the maxillary nerve, the sympathetic nerves, and the inferior ophthalmic vein. Then we have the superior orbital fissure. This is present between greater and lesser wings of the sphenoid bone. And superior orbital fissure is important because it transmits all the nerves which are going to supply the extraocular muscles involved in eyeball movement. That is the oculomotor, trochlear, and abducens nerves, as well as the frontal, nasociliary, and lacrimal nerves, and also the superior ophthalmic vein. Optic canal is located, you can see, supromedial to this superior orbital fissure. And this here is an opening within the lesser wing of the sphenoid. And this transmits the optic nerve and also the ophthalmic artery. And also keep this in mind that in the medial aspect or the medial wall of the gonioper, there present the anterior and posterior ethmoidal foramina, which transmit the nerves and vessels of the same name. So here is the diagram, which is showing us the superior orbital, inferior orbital fissures, and over here the optic canal. Keep this in mind, it will be easier to remember that the superior and inferior orbital fissures, they form an angulated opening which is open laterally. So here are the structures now which are passing through these fissures. Like I told you, in the superior orbital fissure, we have the lacrimal, frontal, and nasociliary branches, which are the sensory branches of the ophthalmic nerve, the first branch of the trigeminal or fifth cranial nerve. And then we have the abducens, which is sixth cranial nerve, and we also have the trochlear, that is the fourth cranial nerve, and the superior and inferior branches of the oculomotor or third cranial nerve, and the superior ophthalmic vein. These are all the structures passing through the superior orbital fissure. Inferior orbital fissure, you can see through here passes the inferior ophthalmic vein, whereas the optic canal is the pathway of the optic nerve and the ophthalmic artery. Now remember that the optic canal and superior orbital fissure, they provide communication of the orbit with the middle cranial fossa. Whereas the inferior orbital fissure, this provides a communication of the orbit with pterygopalatine, infratemporal, and temporal fossae. So these communications are important because any infection within the orbital cavity can spread from the orbital cavity to, you can see, the brain through the middle cranial fossa or into these regions which are the infratemporal, temporal, and pterygopalatine fossa. Now let's come to the contents of the orbit. Starting with the eyelids. We know that the eyelids are the anteriorly placed structures, and they are giving protection to the eyeball, and there is an upper eyelid and there is a lower eyelid, and the fissure between the two eyelids is known as the anterior palpebral fissure. Each eyelid also has muscles. Now, what are the muscles which are present within the eyelids? Well, the first one, the important muscle, is levator palpebrae superioris. This muscle is present in the upper eyelid, right? And it is a skeletal muscle. So it is supplied by the third cranial nerve, that is the oculomotor nerve, and it has a main role in keeping the eye open. There is another muscle also known as superior tarsal muscle present within upper eyelid, which is considered to be a part of the levator palpebrae. But the difference is that this muscle is a smooth muscle and it is supplied by sympathetic nerves. It has a minor role in keeping the eye open. So if there is paralysis of the levator palpebrae superioris due to nerve injury, which can occur due to trauma or tumor or any other cause, it will cause a drooping of the upper eyelid, which is known as the ptosis. If the sympathetic nerve supply is damaged, as in, let's suppose, Horner syndrome, the smooth muscle will not be able to function and superior tarsal muscle will be inefficient, but this will cause partial ptosis of the eyelid since this muscle has a minor role in keeping the eye open. The third muscle in the eyelid is the orbicularis oculi muscle. Now, this muscle is a large muscle. It has two parts. The larger one is the orbital part, and the smaller one, which is in the eyelid, is actually the palpebral part. Now, this is a skeletal muscle. It is supplied by the seventh cranial nerve, that is the facial nerve, And this is present within both the upper and lower eyelids, and its function is to close the eyelids. When we're talking about the contents of the orbit, we also talk about the septum. Now, what is the orbital septum? It is the fibrous sheath that forms the framework of the eyelids. So the eyelids need a supporting framework of fibrous tissue, and this is provided by the orbital septum. Keep in mind, this septum is continuous with the periosteum of the bony orbit, and it has further specializations. One of these specializations are the tarsi, also known as tarsal plates. These are plates of dense connective tissue which are present in the margins of the upper and lower eyelids. The other specialization of the orbital septum are medial and lateral palpebral ligaments. These ligaments are band-like attachments of the tarsal plates to the margins of the bony orbit. On the medial side, the band is attached to the lacrimal crest of the maxilla, whereas on the lateral side, the lateral palpebral ligament is attached to the tubercle on the zygomatic bone. Now here we can see these two diagrams. The one on the left is showing us the orbicularis oculi muscle, which I told you before is the skeletal muscle responsible for closing the eyelids. It has two parts. This part is known as the larger one, which is the orbital part, and then the smaller one, which is present within the eyelids, that is the palpebral part. So this is a circular muscle based on its shape, and it's a skeletal muscle. It is supplied by the facial nerve. Now on the medial aspect and on the lateral aspect, you can see the palpebral ligament. So coming over here on the diagram on the right, which shows us the orbital septum and its specializations in a much more clearer way, we can see this is the lateral palpebral ligament, which is passing from the lateral margin of the palpebral fissure to the zygomatic bone. And on the medial aspect, you can see the medial palpebral ligament, which fans out from the medial aspect of the, you can see the palpebral fissure and is attached to the maxillary bone, right? Also, these specializations of orbital septum are the tarsi, the superior tarsus and the inferior tarsus. These are the plates of dense connective tissue present in the margins of the eyelids. And this is the rest of the orbital septum. You can see over here, this is the tendon of levator palpebrae superioris muscle, which was present for the upper eyelid. This diagram is showing us the section, which is the section in the sagittal plane, so we can get a profile view. And in the side profile of the upper eyelid over here, you can see the muscle, which is orbicularis oculi, and this is its orbital part, and here is now its palpebral part. And you can also see the tendon of levator palpebrae superioris muscle, and here is its skeletal part, and this here is the smooth muscle part, which is also called the superior tarsus muscle, since it attaches to the tarsus of the upper eyelid. Here is the tarsus of the upper eyelid, which I told you is the plate of dense connective tissue. It's a specialization of orbital septum. It also contains within its deeper part the tarsal glands, which are modified sebaceous glands. The oily secretions from the tarsal glands, they increase the viscosity of the tear fluid. So this prevents the spillage of the tears or the overflowing of the tears. And over here is the eyeball, and also you can see the conjunctivae. We will be talking about the conjunctivae in the next few slides. In this diagram, the lower eyelid has also been included. And so you can see this is the lower tarsus. And here is the orbital septum, which I already told you is the fibrous framework of the eyelids. And you can see that this orbital septum, which is providing support to the eye, it is in continuity with the periosteum of the bony orbit. So within the orbital cavity, the glands of the eye are present. I already told you about the tarsal glands, that they're modified sebaceous glands present in the substance of the tarsal plates. They're also known as meibomian glands. And the clinical aspect related to these glands is that if they get blocked or inflamed, they can produce the chalazion on the inner surface of the eyelid. So this here shows us the chalazion due to the blockage and inflammation of a tarsal gland. There are also other glands of the eye, such as the sebaceous glands of Zeiss. These are the ones which open directly onto the eyelash follicles. Also are present the ciliary glands of Moll, which are modified sweat glands, and they open separately between the eyelash follicles. If there is blockage or inflammation of either of these, then this will cause the stye. And many of you might have experienced having a stye, which is due to the blockage or inflammation of either of these glands of Zeiss or Moll, and this is located on the edge of the eyelid. Contents of the orbit also include the very important conjunctiva. Now, what are the conjunctivae? This is a thin, transparent mucous membrane which lines the posterior aspect of the eyelids. Over there, it is called the palpebral conjunctiva, and it is also reflected onto the outer surface of the eyeball over the white portion of the eyeball or sclera, and here it is known as the bulbar conjunctiva. There is a potential space known as conjunctival sac, which is formed when the eyelids are closed, but it opens via an anterior aperture, that is I told you before, the palpebral fissure when the eyelids are parted. The upper and lower extensions of the conjunctival sac are superior and inferior conjunctival fornices respectively. So here is the sagittal section, a simple drawing which is showing us the conjunctiva, the thin transparent mucous membrane. Here it is lining the scleral portion of the eyeball, and it is known as the bulbar conjunctiva, and it is attached to the eyeball just before, or you could say just behind the cornea. And here is the part of the conjunctiva on the undersurface of the eyelid where it is called the palpebral conjunctiva, and between them is this cavity or space which is the superior conjunctival fornix. Also in this diagram, you can see the tarsal glands present on the inner aspect of the eyelid, and also you can see the subtarsal sulcus, which is present 2 millimeters from the margin of the eyelid. And the clinical significance of this sulcus is that foreign particles tend to get trapped within this subtarsal sulcus. If we look at the surface anatomy of the eye, what can we identify on the anterior aspect of the eyeball? Well, we know that the white portion is known as the sclera, whereas in the central region, this is the cornea will cover the anterior aspect of the eye. And in the middle, this black window is the pupil surrounded by the pigmented iris. Here in the medial corner of the eye, also known as the medial canthus, we see this elevation, this pinkish elevation, which is caruncula lacrimalis. On its inner aspect is the lacus lacrimalis. Lacus means lake. This is the site where the tear film, that is the fluid droplets, they tend to collect. And here is the superior palpebral sulcus, and this is the lateral angle of the eye. Now, if we zoom in and we look at the medial aspect of the eye, then we can see that just on the medial aspect of this caruncula lacrimalis is a fold, a pinkish fold of this mucous membrane, which is plica semilunaris. Also, if we look at the medial aspect with the lower eyelid pulled downwards, we can see this depression, which is punctum lacrimalis, present on the elevated area, that is the papilla lacrimalis. Now, this punctum is the site of the drainage of fluid from the eyeball, which we will be talking a little later in the further slides. We'll be talking about that. So, contents of the orbit also include the very important lacrimal apparatus. Now, what does the lacrimal apparatus consist of? It consists of the lacrimal gland, its ducts. Here is the lacrimal gland, the ducts of the lacrimal gland, and it also consists of the lacrimal canaliculi, the lacrimal sac, and the nasolacrimal duct. All these structures are collectively known as the lacrimal apparatus. So if we want to see the site of formation, we can see that this is the lacrimal gland, which produces the fluid, the watery fluid, which we know as tears. So lacrimal apparatus involves it includes all those structures which are involved in the production and then the movement and also the drainage of the tears. So lacrimal gland has two parts, the larger orbital part and then the smaller palpebral part. it produces the watery fluid, which then passes through these excretory ducts onto the surface of the eyeball, as you can see following the red arrows. And then the black arrows are pointing towards lacrimal puncti, which drain the fluid from the lacrimal lake into these lacrimal canaliculi. There is one canaliculus for each eyelid. And then the fluid goes into the lacrimal sac, which is the upper expanded end of this nasolacrimal duct. And the nasolacrimal duct will open into the inferior meatus of the nasal cavity. Now, the lacrimal gland is having two parts, as I told you. The larger orbital part, this one over here, is present within the lacrimal fossa of the frontal bone. Whereas the smaller palpable part of lacrimal gland, it is present in the superolateral part of each eyelid. So keep this in mind. I'm going to the previous slide that in the superolateral margin over here of the orbit is present the lacrimal gland, whereas the lacrimal sac is located in the inner aspect or the medial angle of the eye. Now, contents of the orbit also include the very important bulbar sheath, which is known commonly as Tenon's capsule. This is the facial layer that encloses the eyeball, separating it from the orbital fat. And it is firmly attached to the sclera at the corneoscleral junction anteriorly and the region of the optic nerve posteriorly. The episcleral space is the potential space between the bulbar sheath and the outer layer of the eyeball, which provides a socket for the movements of the eyeball. Okay, so when we talk about the bulbar sheath, it has some specializations. The first is simply that the insertion of the extraocular muscles into the eyeball that is surrounded by a sleeve of this bulbar fascia, and also the medial and lateral check ligaments, they are specializations of bulbar sheath. So over here, we can see that this here is over here showing us the specializations of the bulbar sheath. This is a cross section through the extraocular muscles, the muscle responsible for movements of the eyeball. And this is the lateral rectus muscle, and this is the medial rectus muscle. As they approach their insertion to the eyeball, they are surrounded by this specialization of the bulbar sheath, or you could say it has formed the sleeves around the insertion of these muscles. And these muscles, you can see from them emerge the check ligaments, which is the check ligament from the lateral rectus muscle sheath and also the check ligament of the medial rectus muscle sheath. And then these medial and lateral check ligaments are attached inferiorly by this suspensory ligament. The suspensory ligament is a specialization of the sheath surrounding the inferior rectus and inferior oblique muscles, and it is supporting the eyeball inferiorly in the form of a hammock. So here you can see this is a hammock, and this is the shape of the suspensory ligament, which is supporting the eyeball inferiorly. If we look over here at this diagram, then we can see that we're looking at the eyeball from above. We can see the lateral check ligament and the medial check ligament. These are the specializations, as I told you before, of the bulbar sheath, and they're attached to the bony orbit. And they are continuous to this here, you can see covering of the sheath over the extraocular muscles. And this here is the bulbar sheath. So these are all present in continuity over here. Also present within the orbit is the orbital fat, which surrounds the sides and back of the eyeball, allowing it to move freely within the bony orbit. It has a cushioning effect and provides protection to blood vessels and nerves as they pass through the orbit. Now, before we discuss the extraocular muscles, I would like to talk about the movements of the eyeball. The movements of the eyeball, remember, occur in three axes, considering the direction of movement of the pupil from the primary position. And these three axes are the vertical axis, the transverse, and the anteroposterior axis. So here is the diagram of the eyeball, and these arrows, which are representing elevation and depression, in which the pupil moves superiorly or inferiorly, respectively, represents the movement of the eyeball along the transverse axis, whereas these arrows on the left and right, which represent the movement of the pupil medially or laterally, that is adduction and abduction respectively, these movements occur along the vertical axis. And here these arrows are representing internal and external rotation of the eyeball, in which the upper margin of the pupil, it moves either medially, that is towards the nose, or laterally, that is towards the temple, respectively. These rotatory movements of the eyeball occur along the anteroposterior axis. So the eyeball has extrinsic muscles or extraocular muscles, which are total 7 in number. First is the levator palpebris superioris, we talked about it before. Then come the 4 recti muscles, superior, inferior, medial, and lateral, and then the 2 oblique muscles, superior and inferior. The levator palpebris superioris, we know, is present within the upper eyelid and is responsible for opening of the eyelid, whereas these muscles, which are the 4 recti and the 2 obliques, they are responsible for the movements of the eyeball. The intrinsic muscles of the eyeball are those which are present within the eyeball, and these are the ones which control the shape of the lens, that is the ciliary muscle, and the size of the pupil, that is the sphincter and dilator pupillae muscles. I would like to mention the common tendinous ring when I'm talking about the extraocular muscles. The common tendinous ring is a structure which is present in the posterior aspect of the orbital cavity. It's just a thickening of the periorbital fascia, that is the periosteum of the orbit, around the optic canal and central part of superior orbital fissure. It is also known as the annulus of Zinn. The importance of the common tendinous ring is that it is the point of origin of the 4 recti muscles. So here we can see this is a table which represents a summary of the extraocular or extrinsic muscles of the eye. Levator palpebris superioris, its origin is from lesser wing of sphenoid in the posterior aspect of orbital cavity, and anteriorly it inserts into the skin, the conjunctiva, as well as into superior tarsus. It is supplied by oculomotor nerve, that is the skeletal part of the levator palpebris superioris, and we know it elevates the eyelid. Now let's come to these muscles, which are the 4 recti, superior, inferior, medial, and lateral. They're all originating from the common tendinous ring, and they're all inserted into the anterior half of the eyeball. The superior rectus is supplied by oculomotor nerve, as well as inferior rectus and medial rectus. The exception is the lateral rectus, which is supplied by the abducens nerve, that is the 6th cranial nerve. Then come the oblique muscles, which are superior and inferior oblique. Superior oblique has its origin from the body of sphenoid bone, and whereas the inferior oblique, this is the only muscle which is not arising from the posterior aspect of the orbital cavity, but its origin is from the floor of the orbit anteromedially, and you can see the insertion of both of these oblique muscles is into the posterior part of the eyeball. So the nerve supply, you can see superior oblique is supplied by trochlear nerve, right? Whereas inferior oblique is supplied by the oculomotor nerve. So all the muscles of the eyeball, when we talk about the extrinsic muscles, you can see they're all supplied by the 3rd cranial nerve, that is the oculomotor nerve, the exception being the lateral rectus, which is supplied by the 6th cranial nerve, and the superior oblique, which is supplied by the 4th cranial nerve. Now, when we talk about the actions of these muscles, they all have different actions. And you can see that the abduction of the eyeball is mainly performed by lateral rectus, but this abduction is also, you could see, being performed by the other muscles, which are the obliques, the superior and inferior obliques. Similarly, the main muscle involved in adduction of the eyeball is medial rectus, but it is supported in this action by both superior and inferior recti. Then, as the name shows, superior rectus elevates the eyeball, inferior rectus depresses the eyeball. And in case of the obliques, it is the reverse. The superior oblique depresses the eyeball, but inferior oblique elevates the eyeball. And then coming to the action of intorsion and extorsion, we can see both the superior muscles, that is superior rectus, and over here the superior oblique, they intort the eyeball, that is they provide the medial rotation, also known as internal rotation of the eyeball. Whereas the inferiors, that is inferior rectus and inferior oblique, they are external rotators of the eyeball. If you want to remember the nerve supply, you have the mnemonic, that is the SO4 LR6O3. SO4 simply means that superior oblique is supplied by the fourth cranial nerve. LR6 means lateral rectus is supplied by the sixth cranial nerve. And O3 means that all the others, they are going to be supplied by the third cranial nerve, that is the oculomotor nerve. And here is the diagram again showing the posterior aspect of the orbital cavity, where we have this superior and inferior orbital fissures, and surrounding the superior orbital fissure and optic canal is this common tendinous ring. And from this common tendinous ring, you can see the origin of the superior rectus, and you can see the origin of inferior rectus. And here is the medial rectus, and this is the lateral rectus. And supromedial to the common tendinous ring in the posterior aspect of orbit is the origin of levator palpebris superioris, and you can see the superior oblique. Okay, so now I would like to come to the simple concept map, which is going to help us understand the actions of these muscles. And for that, I'm going to draw the right eye, and we're going to see how we can memorize the actions of, or we're talking about the main actions of the extraocular muscles. So here, if I would draw the right eye, this is the part of the cornea which has the pupil in the center and then the pigmented iris. And if considering that this is our right eye, then we can see that this here is the nose, and we are viewing the right eye from in front. Now we want to understand and also remember the actions of the muscles which are responsible for the movements of the eyeball. Now, if the right eye, you can see the direction of movement which is medially, that is, if the pupil is moved medially, then this is known as adduction. And I told you before that this takes place in a vertical axis. Now, the main muscle responsible for adduction is the medial rectus, which I'm just writing right now as MR. Medial rectus is the main adductor of the eyeball. And the opposite movement of the eyeball, that is moving the pupil laterally, this is performed by the muscle which is lateral rectus, and the movement is known as abduction, right? So abduction is performed by LR, that is the lateral rectus muscle. These are the movements occurring in the vertical axis. Now let's look at the other movements which take place in the transverse axis. This is the upward movement of the eyeball, or you could say the pupil is going to be moving superiorly. This movement is known as elevation. And elevation is performed by the superior rectus, that is SR, right? Whereas the movement of the pupil inferiorly, this is known as depression. And this movement is performed by the inferior rectus, that is IR, right? The inferior rectus muscle, it performs depression of the eyeball. Now, these four are obviously easy to remember, but here comes the tricky part, the part which we want to keep in mind. So for that, I'm going to draw two diagonal lines. Now, the first line over here that I'm drawing, now this is the SR on top, And let me write down over here SO below. So you have to write SR over here. You could say here is SR, so here comes its buddy, the SR over here, and then SO down over here. I have drawn this diagonal line over here. I'm going to draw another diagonal line, and this time with the IR, I'm going to write IR over here, okay? And I'm going to write IO over here. So I have drawn these two lines. SR means superior rectus, SO stands for superior oblique. And over here, the IR stands for inferior rectus and IO stands for inferior oblique. Now, what I want to show you is the movement which is occurring in the antero-posterior axis. Now, antero-posterior axis passes through this point and it produces a movement which is known as either intorsion or extorsion. Intorsion is the movement inwards of the upper margin of the eyeball, that is towards the nose. This movement is known as the medial rotation or the intorsion, also known as the internal rotation. But right now, I'm simply going to describe this movement as intorsion. If we're viewing the right eye from in front, we could say if 12 is the midline, then 1 o'clock movement is the intorsion, or that is the clockwise movement of the upper margin of the pupil. Here is the reverse movement, which is extorsion, also called the lateral rotation or the external rotation of the eyeball. This is a movement in which the upper margin of the pupil is going to move over here towards the temple. That is, we could say this is the movement in an 11 o'clock direction in case of the right eye when viewed from in front, or this is also, it can be said, this is the anti-clockwise movement, right? Now, these movements, intorsion and extorsion, are occurring around this antero-posterior axis. Now, how to remember the muscles which are responsible for these movements? Well, first we shall follow this diagonal line over here and encircle the S for superior rectus, S for superior oblique. These are the two muscles which perform the movement of intorsion of the eyeball. Now, coming over here, if we follow the other arrow, we're going to encircle the two eyes, I for inferior oblique and I for inferior rectus. These are the two muscles which perform extorsion. Okay, so this is how we can remember that. Okay, also what I want to see over here, what I want you to focus on is that these muscles which we have mentioned on the upper part of the diagram, that is the, you can see over here, this is superior rectus, this is inferior oblique. These are the two muscles which are responsible for the elevation of the eyeball. Whereas these muscles which we have mentioned in the lower part of the diagram, the superior oblique and inferior rectus, these are the muscles both which carry out depression of the eyeball. That is their main action. Okay, also what we want to look over here is that on the medial aspect, we've got three muscles over here in this diagram. These three muscles are the superior rectus, the medial rectus, and the inferior rectus. They all perform the adduction of the eyeball. So these three muscles perform adduction of the eyeball, and on the lateral aspect, what we have are inferior oblique, and we've got the lateral rectus, and we've got the superior oblique. Now, these are the muscles which perform the abduction of the eyeball. So the two obliques and lateral rectus are abductors of the eyeball, whereas the medial rectus with superior and inferior recti are the adductors of the eyeball. So this is a concept map which I drew for you. This will help us remember the main actions of the muscle when we are considering their actions from the primary position. Okay, so coming back to our slides, let's go back to our slides over here. And when we were talking about the main actions, we can also summarize these actions. Now, these actions which we were talking about are the obliques are abductors of the eyeball, and lateral rectus is the main abductor. The superior inferior recti and medial rectus are adductors of the eyeball. The MR, remember, is the main adductor. It is supported in this action by SR and IR. Elevators of the eyeballs are superior rectus and inferior oblique, but depressors of eyeballs are inferior rectus and superior oblique. SR and SO are both the medial rotators of eyeballs, and IR and IO are the external rotators of the eyeballs. So just keep in mind that the obliques, they abduct the eyeball, but recti, all of the recti except lateral rectus, they adduct the eyeball. And the superiors, they intort, and inferiors extort the eyeball. The recti, they act according to the names, but obliques act opposite to the names when we are considering the action of elevation and depression. So this is how we can remember the main actions of these muscles. So coming over here now to our recti muscles. Okay, so when we talk about the recti muscles, we know the rectus word is derived from the Latin language and it means straight. This is because their pathway is direct from the point of origin to insertion. So this is something we have to keep in mind about the origin of the word, the name rectus of these muscles. Okay, so superior inferior recti, you know the origin is from the apex of the orbit. And keep in mind that their origin is medial to the axis of the eyeball when the eyes are looking directly forwards. So as these muscles, they pass forward towards their insertion into the anterior part of the eyeball, they are also directed laterally. Although their body of the muscle is straight, but the direction of the muscle fibers is laterally, lateral to their point of origin. And this explains their action. So here is the view of the eyeball within the orbit from above. And you can see the origin of this here, superior rectus muscle. It is medial. And here you can see the eyeball, which is facing directly forwards. This would be the axis of the eyeball. And the point of insertion of this muscle, you can see the pathway of this muscle, although the body of the muscle is straight, but it is directed laterally through the orbit. And this here shows us the axis of the orbit, and this shows us the axis of the eyeball. But in case of the medial and lateral recti, their orientations and actions are much more straightforward than those of the superior inferior recti. And when we talk about the superior inferior obliques, the thing to remember about these muscles is that their origin is not from common tendinous ring. Also, their approach to the eyeball is angular and it is not direct. That is why they're called oblique muscles. Also, their insertion is into the posterior half of the eyeball. So let's look at the superior oblique muscle we have over here. So superior oblique, you can see, is this muscle directly where you can see the laser pointer. This is representing the superior oblique muscle. Its origin is from the posterior aspect, that is the apex of bony orbit, but not from the common tendinous ring. It is from the sphenoid bone. And as it is passing forwards, it passes through this trochlea. So what is the trochlea? The trochlea is simply a fibrocartilaginous pulley, which is present on the inner aspect of the frontal bone. Okay, and you can see that the superior oblique muscle, it passes through this trochlea, and then it passes posterolaterally to be inserted into the outer posterior quadrant of the eyeball. So this shows us the pathway of the superior oblique muscle. Okay, and when we look at the inferior oblique, remember its origin is from floor of the orbit, not from the posterior aspect of orbital cavity. And this muscle, it then passes posterolaterally and is also attached to the outer posterior quadrant of the eyeball below the lateral rectus muscle. So while the superior oblique muscle passes beneath this superior rectus, the insertion of inferior oblique is below the lateral rectus. Superior oblique is inserted above the lateral rectus, and this here inferior oblique is inserted below the lateral rectus. Now we can understand these extraocular muscles in a much better way if we are going to look at a three-dimensional model. Okay, so now we are looking at the three-dimensional model of the orbital cavities. And over here, we can see these two arrows, which are showing us the main two axes of the orbital cavity, which I had mentioned in the very initial slides of this presentation. The blue arrow is representing the axis of the eyeball, which runs through the central part of the pupil when the eyes are facing anteriorly. Whereas this green arrow is representing the axis of the orbit. And over here, if we look at the extraocular muscles now, we can see that they are the ones responsible for the movements of the eyeball. And here is the superior rectus. If you just follow the pointer, this is the superior rectus. And as the name rectus indicates, it has a straight axis, but you can see that its origin is from the posterior part of the bony orbit, from the upper part of the common tendinous ring, and as it moves or passes forwards, it becomes laterally directed because of the axis of the orbit. So the origin, you could say, is medial to the insertion. And the insertion of superior rectus is into the anterior half of the eyeball, into the sclera, just behind the cornea. Also, you can see if we zoom in to this model, then we can see the inferior rectus muscle over here. This is the inferior rectus muscle. Its origin is also from the posterior part of orbital cavity, the common tendinous ring, that is the inferior part of common tendinous ring. It passes forwards and it becomes attached to the anterior half of the eyeball into the sclera just before the beginning of the cornea, right? So this is the inferior rectus muscle. Now we can see this here is the lateral rectus muscle. The lateral rectus muscle is also having its origin from the posterior aspect of the bony cavity, that is the apex, that is from the lateral part of the common tendinous ring, and it passes forwards and becomes inserted into the lateral side of the eyeball, into the anterior half of the eyeball. So you can see on the medial aspect, this is the medial rectus muscle now. Medial rectus muscle also has its origin from the common tendinous ring, the medial part of common tendinous ring in the posterior part of bony orbit, and it becomes inserted into the medial side of the, you could say, anterior part of the eyeball, just behind the cornea. So these are the four recti muscles. Also, we can see the obliques. This is the inferior oblique muscle. Inferior oblique muscle is unique in that its origin is not from the posterior part of the bony orbit, but anteromedially from the floor of the orbit, and then it passes below the medial rectus muscle, and it becomes inserted, you could see, posterolaterally into the outer posterior quadrant of the eyeball, just below the lateral rectus muscle. Let's look at the superior oblique. The superior oblique is the muscle which has its origin from the posterior part of the orbital cavity, but not from the common tendinous ring. Its origin is from the body of the sphenoid bone. It travels in the upper part of the orbital cavity. You can see over here it is traveling in the upper part of the orbital cavity. This is a better view showing us the superior oblique muscle. It is present within the upper part of orbital cavity in the medial aspect, and here anteriorly it turns on the trochlea, which was the fibrocartilaginous pulley on the inner aspect of the frontal bone, and then its fibers, they pass posterolaterally to be inserted into the outer posterior quadrant of the eyeball below the superior rectus muscle. So this is the insertion of the superior oblique, which is below this muscle, which is the superior rectus muscle. So this is how we see that these are the superior rectus, the lateral rectus. This is the superior oblique. And over here, we can see the inferior rectus. And this was the medial rectus. And this here is the inferior oblique. So now that we've understood the orientation and the situation of these extraocular muscles in a 3D model, we can come back to our PowerPoint slides and we will talk about the clinical test of the extraocular muscles. Now, if we want to check the individual actions of the extraocular muscles, the clinician performs a test on the patient known as the H test, or we could say he makes an H sign. Now, how is this test performed and why is it called the H test? Well, if you look over here, just follow the pointer, starting from the neutral position or primary position, which is when the eyeball is looking forward, straight forwards anteriorly. The person whose extraocular muscles are being tested, in this case, it's the anterior view of the right eye. The clinician or the doctor uses his finger, or he can use a pen and ask the patient to move his eyeball inwards or look in the medial direction. In that case, the movement of the eyeball would be confirming the integrity of the medial rectus muscle, because we know adduction is the movement of pupil in a medial direction, and this is mainly performed by the medial rectus muscle. Then the patient, after moving the right eye in a medial direction, would be asked to move the eye upwards. Now, if the patient moves the eyeball upwards, this is now, we are now checking the integrity of the inferior oblique muscle. And then the patient is asked to look downwards, which checks the integrity of superior oblique muscle. Then coming back to the neutral position, the patient is now asked to look outwards, that is in the lateral direction. In case of the right eye, we would simply ask the patient to look towards the right. And in this case, we're checking the lateral rectus, which is performing the main action of abduction. And then in the abducted position, now the patient will be asked to look upwards, which checks for integrity of superior rectus muscle. And then the patient will be asked to look downwards, which checks for the integrity of the inferior rectus muscle. So this makes an H sign, and we have checked the individual actions of the extraocular muscles. Now, the question which comes to mind is that when the eye is abducted, in that situation, we are checking for the actions of superior and inferior recti. Now, what would be the reasoning behind this is that when the eye is going to be abducted, you can see in this diagram over here that the eyeball is directed outwards or laterally. So it is in the abducted position. What happens is that in this position, the long axis of the superior and inferior recti comes in line with the axis of the eyeball. So here is the axis of the eyeball, and now it is in line with this, or you could say parallel to the long axis of the superior and inferior recti. Here, the axis of the eyeball can also be called simply the angle of the gaze. Otherwise, if the eyeball was not abducted, and if the person is looking forwards, in that case, there would be an angle of 23 degrees between the long axis of the muscle and the angle of gaze. Similarly, in case of the obliques, we test the obliques with the eye in the adducted position, because if this position is like so, if it is adducted, that is towards the nasal region, then the line of axis of these muscles, this is representing the line of axis of the obliques. You can see this is the line of axis. If you follow the pointer, this is the line of axis. This will come in line with the angle of gaze. So when the eyeball is being adducted, remember the line of axis of the oblique muscles comes in line with the angle of gaze. Otherwise, if the person would be looking straight forwards, as in anteriorly, that would produce a 51-degree angle between the axis of the muscle and the angle of gaze. Now, when we were talking about contents, we discussed the extraocular muscles in much detail. Also keep in mind that the blood vessels are present within the orbital cavity. The blood vessel to remember when we're talking about the arteries is the ophthalmic artery, which enters the orbit through the optic canal with the optic nerve. And then this ophthalmic artery gives off multiple branches within the orbital cavity, including the central artery of the retina. You can see over here, this is the central artery of the retina, which travels with the optic nerve to the eyeball, and its branches can be visualized with the ophthalmoscope. The other branches given off by ophthalmic artery are, you can see the supraorbital and the supratrochlear, anterior and posterior ethmoidal, as well as the short and long posterior ciliary branches and the lacrimal artery. The veins which are present within the orbital cavity are mainly the superior ophthalmic vein, which is present in the upper part of orbital cavity. It is formed by the union anteriorly of the angular and supraorbital vein, and it drains into the upper part of the cavernous sinus. In the lower part of orbital cavity is the smaller inferior ophthalmic vein, which also drains into the cavernous sinus either directly or indirectly through the superior ophthalmic vein, and it is also having communications with pterygoid venous plexus in the infratemporal fossa. So this concludes with today's discussion on the orbit, in which we covered all the essential aspects of the contents of the orbit, and we talked in detail about the extraocular muscles, their main actions, and then how to test for these extraocular muscles. If you found today's topic helpful and it increased your knowledge and gave you a better understanding of the actions of the extraocular muscles, as well as the anatomical structures present within the bony orbit, then please like and subscribe to my YouTube channel. And you can do that by simply pressing on my picture, which is going to pop up at the end of this YouTube video. So stay blessed and enjoy your studies, and take care till next time. Allah Hafiz.